Croeso, welcome to this instructional video on the management of epistaxis or nosebleed in the emergency department and on the ward. We will discuss the classification and anatomy, initial management, cauterization and nasal packing. Causes can be classified as local or systemic. Local causes are iatrogenic, such as nasal sprays or surgery, inflammatory, for example rhinosinusitis, or traumatic. However, idiopathic causes make up the vast majority at 85%. Less obvious are the systemic causes, such as hereditary hemorrhagic telangiectasia or coagulopathies and platelet disorders. Starting a new rotation can be extremely stressful for junior doctors, especially when you are expected to undertake a lot of new procedures. To make things simpler in Swansea Bay, we have a 6-step management algorithm for epistaxis. This can be followed from ABCDE resus, simple first aid, cautery, as well as nasal packing and surgical intervention. Step 1. ABCDE resus. As with any hemorrhage or trauma, epistaxis can lead to patients becoming hypovolemic and fatalities are not unheard of. Don't forget to use the ABCDE resus approach to the patient and ensure they are stable. Airway compromise and breathing difficulties arise with traumatic epistaxis, but also with posterior bleeding. It is important to achieve good IV access in the emergency department before admitting to the ward, as the patient will require samples for a full blood count, urea and electrolytes, liver function tests, and a clotting profile. It may also be necessary to give fluid resuscitation plus or minus blood products. Step 2. Simple first aid. Once you are satisfied that your patient is stable, your priority is then to control the bleeding and maintain the airway. Try to keep the patient as calm as possible. Ask them to sit down and lean forward over a sink or kidney bowl, which keeps the nose above the level of the heart, further aiding to reduce bleeding. Ask the patient to breathe through their mouth and pinch the soft, fleshy part of their nose firmly. This is the standard first aid position, and they should apply this pressure constantly for at least 20 minutes without peaking, after which time they should take a brief pause to assess if the bleeding has stopped. It may be useful to have the patient suck on some ice or place ice packs on the bridge of the nose. Do not let them lie down or lean back, as this encourages blood to flow backwards and potentially enter and obstruct the airway. It is also important to ask the patient not to speak, swallow, cough or sniff, as this may disrupt the clotting process within the nasal cavity and prolong bleeding. They should, however, be encouraged to spit out any blood from the mouth, as it is emetogenic and could lead to vomiting. Step 3. Examination and identification of the bleeding point. The next step should be to try to establish where the bleeding is coming from. The vast majority of bleeding is anterior, originating in Little's area, alternatively known as Kieselbach's plexus on the medial septum. Apart from where they are located, there are some important differences between anterior and posterior bleeding. Anterior bleeding is more common in younger people and easier to manage. Bleeding will be predominantly from the nostrils, initially from one nostril only, but it can sometimes trickle to the throat, especially on tilting the head backwards, applying first aid, or when the nose is full of clot. A small minority of bleeds are posterior and originate from Woodruff's plexus. They are more commonly seen in elderly people and are often more difficult to manage and more dangerous. Unlike the anterior bleeds, the majority of the blood goes down the postnasal space into the throat as well as out of both nostrils. Bleeding will also continue to be brisk despite anterior packing. Step 4. Nasal cautery. Be prepared before you start. Protect yourself and gather all the equipment that you will need so that it's within arm's reach. Shown here is a typical trolley for dealing with epistaxis. On it you should have a Thudicum's nasal speculum, a tongue depressor, anaesthesia, we prefer phenylephrine plus lidocaine solution, suction. A Yanker is often too big for anterior bleeds, so a smaller Fraser suction tip or equivalent is more suited. A size 12 female urinary catheter or Foley, all posterior packs, silver nitrate sticks, rapid rhino anterior packs, and Naseptin cream. Bear in mind this cream contains peanut, so ask about allergies and consider Batraban as an alternative. There are 4 stages for nasal cautery, shown here for later reference. Anaesthetise the patient if needed. Use a good light source and explain the procedure to the patient. Give them a kidney dish and position them correctly. They should be sat upright in a chair and you should be sat close. The positions for both right-handed and left-handed doctors are shown. To administer the anaesthetic, squirt 3 or 4 puffs up either nostril and ask the patient to sniff. Wait about 10 minutes for it to work. Cotton wool soaked in anaesthetic should be placed against the bleeding site once it is identified. Ask the patient to adopt the standard first aid position, pinching the soft part of the nose for 5 minutes with an open mouth, head tilted forward over a kidney dish. Place Vaseline or paraffin under the patient's nose. When the silver nitrate is exposed to skin, it can tattoo the skin, and you don't want to leave your patient looking like Charlie Chaplin, or worse. Remove the cotton wool gently. If the bleeding has stopped or is light, then it's time to cauterize the bleeding area. You might find it easier to bend the silver nitrate stick to give you a better angle to work with. Adopting the same position as before, use Thudicums to visualize the bleeding point. Position is shown here for both right and left-handed doctors. Apply the head of the silver nitrate stick to the mucosa around the bleeding point, leaving the stick in contact for 10 seconds. Use good pressure with a cauterizing agent. Don't just paint the mucosa. Do this so that there is a small circle of cauterized mucosa around the bleeding point, targeting smaller vessels and collateral blood supply first. Finally, cauterize the bleeding point itself. Insert freshly soaked cotton wool to flatten any crusting and prevent displacement. If this is successful, keep the patient in the department for an hour to ensure no further bleeding. Give them the Naseptin cream, but be aware that it contains peanut, so avoiding nut allergies. If the patient rebleeds, consider repeating the above steps or the need for nasal packing. Step 5. Anterior packing. Be prepared before you start. Protect yourself and gather all the equipment that you will need so that it's within arm's reach. Shown here is a typical trolley for dealing with epistaxis. On it you should have a Thudicum's nasal speculum, a tongue depressor, anaesthesia, we prefer phenylephrine plus lidocaine solution, suction. A Yanker is often too big for anterior bleeds, so a smaller Fraser suction tip or equivalent is more suited. A size 12 female urinary catheter or Foley, all posterior packs, silver nitrate sticks, rapid rhino anterior packs, and Naseptin cream. Bear in mind this cream contains peanut, so ask about allergies and consider Batraban as an alternative. In addition to this, have ready some ribbon gauze and a 10ml syringe filled with air. As this may be a significant bleed, ensure you have good venous access before you begin to pack. There are 4 stages for anterior packing, shown here for later reference. Anaesthetise the patient if needed. Use a good light source and explain the procedure to the patient. Give them a kidney dish and position them correctly. They should be sat upright in a chair and you should be sat close. The positions for both right-handed and left-handed doctors are shown. Use nasal thidicum to visualize the nasal floor prior to insertion. This allows for compensation for differing anatomy, for example a deviated septum. This is a very uncomfortable experience for patients, so please ensure that they are written up for good analgesia, including opiates. Remember that the floor of the nose lies in the horizontal plane. It is natural for the patient to tilt his head upwards. Discourage this as it makes your orientation harder. Insert the pack, keeping as close to the floor of the nose as you can. Slowly inflate up to 10 ml of air, reassessing hemostasis. The tubing from the rapid rhino should be taped to the patient's cheek, as shown. Post-pack care is important. You might also consider placing nasal bolster to collect any hemoserous ooze. If this is unsuccessful, repeat the process again with the other nostril to tamponade the septum. If the packs fail to achieve hemostasis and blood continues to trickle down the back of the throat, or if it is clinically evident that there is a posteriorly situated bleeding point, then you will need to discuss management options with the registrar on call. Step 6. Posterior packing. Posterior packing should be undertaken by a senior registrar, but you should still be aware of how it's done and be able to get the equipment ready. By this stage, the patient will still be bleeding down their throat and have 2 nasal packs fully inflated with 10 ml of air each. As the patient is becoming increasingly likely to need surgical intervention, such as sphenopalatine artery ligation and general anaesthetic, the patient should be kept nil by mouth. You need to prepare a size 12 Foley catheter, an umbilical clip, gauze, tongue depressor, and 2 further rapid rhinos. A Foley's catheter is not licensed in the UK, and where able, specialised posterior packs should be utilised. However, this method can be used where specialist packs are unavailable, using readily available equipment and a well-recognised technique. Once again, the patient may require anaesthetic. Your registrar will adopt the same position as for anterior bleeding, with good lighting and protective clothing. Shown here are both the right and left-handed positions. Once all prior packing has been removed, the procedure can begin. Insert the catheter into the nostril parallel to the floor of the nasal cavity. Pack the side with the greatest bleeding. Advance the catheter until the tip can be seen in the oropharynx. Inflate the balloon with 10 ml of water, not saline, and pull the catheter until the postnasal space and the corona is occluded. Keep hold of the catheter and ensure the patient keeps their head still or rested against a bed. Then insert the rapid rhino alongside the catheter using the same technique as for anterior packing. Finally, use an umbilical clip to clamp the catheter, preventing the balloon from falling posterior inferiorly. It is vital to place gauze in between the clip and the skin of the alar area to prevent alar necrosis. It is worth mentioning that not everyone follows this algorithm, and so you may find that some patients have received anterior packing without nasal cautery. Patients with the nasal packs will need admitting. Packs that have stayed in situ for longer than 24 hours may pose an infection risk, and prophylactic antibiotics should be considered at this stage. Discuss with the on-call registrar regarding this. In any event, the pack will need removing in order to cauterize. It should be done so gently with the application of water around the pack in order to soften it. Remember, when dealing with epistaxis, if you follow the algorithm, you will not go far wrong. Thank you for watching. Hwyl fawr.